bob back and forth as they try and take their breaths. This indicates extra effort in their breathing pattern. Retractions
Could we
are
back the
next
video
thing
up a
you
little
want to
bit?
be aware of.
Absolutely.
Okay.
You can see. First, let's talk about how to perform a comprehensive respiratory exam. This exam is going to be made up of 3 key parts: the look, listen, and feel model. Before we start, let's talk about a few basic terms that you'll need to be familiar with. The first is that of tachypnea, otherwise known as a fast breathing rate. Bradyapnea is the term we use to describe a low breathing rate. Apnea describes the patient is not breathing at all or has a respiratory rate of 0. Dyspnea, or respiratory distress, speaks to the patient's difficulty in their ability to breathe. As you'll notice, the patient in front of me here is intubated or has an endotracheal tube in their mouth to assist their breathing. Some of your patients in the ICU will have a breathing tube and others will not. The basic principles of our respiratory exam are going to be the same for both intubated patients and extubated patients. Any differences that are important will be highlighted throughout this video.
Physical exam.
As we said, the physical exam has 3 parts. You want to look, listen, and feel your patient. The first step is to just take a look. You can always gain a great amount of information simply by looking at the general appearance of your patient. First, you want to ask yourself, how does this patient's breathing look? Do they look calm and comfortable? Are they in a position where they're trying to put themselves in order to breathe more easily? In an extubated patient that's ill, they'll often try to find a position of comfort, one in which they're able to breathe the easiest. For a baby with croup, that may be in their mother's arms where they're calm and comfortable. It is always best to leave an extubated patient in the most comfortable position for them, especially while you're performing your exam. You may see a patient tripoding or actually on their hands and knees, bent over, hunching, or you may notice that they're drooling a lot. Next, you want to look at their face. Do they look afraid? Are they having a hard time breathing? Do they look drowsy, lethargic? Are they not responding to you at all? Are they anxious, irritable, restless? All of these things can indicate that they are not effectively breathing. Next, you want to look at their overall skin color. Do they look pale? Are they mottled? Do you even notice some cyanosis or a bluish tint to their color? You may notice these things around their lips, which is known as circumoral cyanosis. You also may see that their hands or their feet appear a little bit blue. These things could indicate they're not getting enough oxygen. Next, you want to take a look at the child's trachea, which is located midline in their neck. You always want to assess and make sure that that trachea remains in the middle of the neck position. If the trachea has moved to either side, that could indicate that the patient is experiencing a pneumothorax. The next thing you want to assess for is the respiratory rate. This can be done simply by watching your patient breathe. What you want to do is count for a minimum of 30 seconds to see how many breaths the patient takes. It is very important to count for this long because infants and children often have some variation in their respiratory pattern, and if you don't count long enough, you may end up with an inaccurate respiratory rate. The normal rates for patients should be as follows. In newborns, you can expect the baby to breathe between 30 and 60 breaths a minute. For young children, it should be about 20 to 40 breaths per minute. In an older child, anything from 15 to 25 breaths per minute is acceptable. In the adult patient, 12 to 20 breaths should be expected. The next thing you want to assess is whether or not that breathing pattern is regular or irregular. Do you see the patient breathe at a nice, steady rate, even if it is fast, or are they taking very quick breaths and then having pauses in their breathing? These are important to note. In many normal pediatric patients, there is some variation in their respiratory pattern. However, if the patient is taking very quick breaths and then all of a sudden stops or slows way down and the breathing rate picks back up again, this can be a very ominous sign of impending respiratory failure. In addition, in a baby or a small child who is breathing too slow, that can also indicate that a child is experiencing respiratory distress and soon to be failure. Next thing we want to look for is if the child is experiencing any drainage from their nose, from their mouth, from their endotracheal tube. All of these things should be assessed for color, consistency, and their amount. It could be a small, moderate, copious. They could be thick, thin, white, clear. The color will often indicate the type of drainage that the patient is having. Clear drainage will often indicate normal secretions. Yellow or green secretions often indicate that the child has some sort of a bacterial infection. Next, we want to look for any signs that it's hard for your patient to breathe. We call these signs and symptoms of respiratory distress. You will often see that a child is using extra muscles or ways to get a good solid breath in. The first and most common thing that we see in children.
Okay, well, we'll come back to respiratory distress. Any questions about the video?
No, we're good.
Yeah, good. You see the screen, right? Back to the slides?
Yes.
Excellent, thank you. Okay, so just a review for respiratory distress, inability to maintain gas exchange. There are multiple etiologies leading to distress. Signs and symptoms are vary depending on the age. Abnormal, you'll see abnormal respirations, tachypnea, bradypnea, apnea, retractions, accessory muscle use, such as also you'll see head bobbing. It's important to provide a position of comfort, nasal flaring, grunting, color changes, and more from late stage of our respiratory distress, which is a respiratory failure. You'll see poor aeration and altered mental status. So depending on where the pathology is, there are some sort of a giveaway signs and symptoms that you can distinguish where, the issue is. For example, if there is a stridor and hoarseness, change in voice or cry, then the issue is in the upper airway, right? If you hear any expiratory wheeze, then that it is a lower airway obstruction, whether it's, asthma or bronchiolitis, but where the issue is. If there is any grunting, any crackles, then the issues with the lungs itself, and abnormal control of ventilation category. So whenever you hear abnormal control of ventilation or breathing, it stands for CNS involvement. Can some of you think about what will be abnormal control of ventilation examples? So what would be like a clinical cases that will say, okay, this is a CNS that got involved, so therefore we see abnormal control of ventilation as a result of a CNS involvement. So some of the examples are, sorry?
Trauma or meningitis?
Exactly, trauma, meningitis, could be, for whatever reason, increased ICP, right? So could be some structural lesions, could be as, over sedation as a result of, narcotic administration. So post-op patient, right? Or sedation for procedure. Also post-ictal patients after they experience a seizure episode, or maybe after they receive the medication to control their seizures. So whenever we talk abnormal control of ventilation, so it is a CNS system that is involved. So what are the interventions whenever we have a child in a respiratory distress to promote position of comfort? So depending on the age of the child, position of comfort looks different. If it is an infant or toddler, separation anxiety is huge. So you really want them to be held by their parents, caregivers, right? To sit them on their lap or to hold them in their hands, right? For as long as they're able to maintain their airway, right? For an older child, it'll be semi-Fowler or a high Fowler position, again, whenever they're able to maintain their airway. So as we all know, without interventions, respiratory distress can progress to respiratory failure and respiratory arrest. So how do you distinguish when the patient is in a respiratory distress, respiratory failure, or respiratory arrest? So it is a continuum, right? But once when patient is in a respiratory distress, so patient does have compensatory mechanism in, and the heart rate goes up, respiratory rate goes up, usually saturation is still fine, level of consciousness is still fine. Respiratory failure is characterized by already inadequate oxygenation, ventilation, or both. Patient can no longer compensate to maintain adequate gas exchange. Fatigue is often precipitating factor, and whenever we do ABG analysis, so we see there is a significant respiratory acidosis and abnormal blood gas. Respiratory arrest happens when respiratory distress and failure that progress, right? So untreated respiratory distress progresses to respiratory failure, and respiratory failure progresses to respiratory arrest and cardiac arrest. So respiratory arrest is basically characterized by absence of breathing or gasping or agonal breathing, and it's an ominous sign of cardiac arrest. Any questions so far?
Oh, we're
Okay.
good. Thanks.
Okay, great. Please let me know if do you see the video?
Yep, we can hear.
You could hear?
Yep.
Excellent.
Recognizing Respiratory Distress and Failure by Dr. Monica Kleinman.
When we say respiratory distress, we're really referring to the use of compensatory mechanisms to maintain adequate oxygenation and ventilation when something, one of many things, is causing respiratory compromise. Typically, the compensation consists of an increase in the rate and work of breathing. That increase will increase minute ventilation, allowing the child to exhale more carbon dioxide when gas exchange is impaired. Signs of respiratory distress include retractions, sternal retractions, for instance, because of the flexible, compliant breastbone, as well as intercostal retractions. And this is an example of increased effort resulting in muscles exaggerating the spaces between the ribs or in the sternum. Use of accessory muscles, such as the strap muscles in the neck, nasal flaring, and grunting, an expiratory noise that's designed to apply some PEEP. Children in respiratory distress typically are anxious. This is an uncomfortable feeling, and with that stress, they oftentimes have tachycardia. These are some examples as well of signs of respiratory distress. The child who wants to sit upright and is unable to lie flat comfortably. The child in the left looks anxious, and the child in the right is demonstrating increased work of breathing. Respiratory failure, on the other hand, is at the other end of the spectrum and is defined by inadequate oxygenation and ventilation. Essentially occurs when compensatory mechanisms fail to maintain gas exchange. Interestingly, respiratory failure can occur without preceding respiratory distress, meaning it can happen when there is depression of respiratory effort, typically by something like a poisoning, which depresses mental status, or seizures, or severe weakness, leading to inadequate respiratory effort. Signs of respiratory failure when the compensatory mechanisms are no longer able to sustain gas exchange include desaturation or cyanosis despite supplemental oxygen, the appearance of increased effort leading to poor air entry. In other words, lots of work for very little gain. This may be characterized by a sound of gasping when the child inspires, head bobbing, which is an exaggerated form of accessory muscle use in which the head literally will bob as the muscles of the neck and shoulders are trying to participate in gas exchange. Seesaw or paradoxical respirations, where the abdomen and chest move in the opposite ways than they usually do. And sounds of severe obstruction, such as stridor. The hallmark of respiratory failure, to distinguish it from respiratory distress, is a change in mental status. When oxygen levels fall and carbon dioxide rises, this is a very stressful feeling and results in sympathetic stimulation and agitation. As carbon dioxide continues to rise, it has a sedating effect on the central nervous system, leading to a child who's lethargic, sleepy, or obtunded. The child who appears to have increased work of breathing, desaturation, and sleepiness or obtundation is one in whom you need to be very concerned has transitioned from respiratory distress to respiratory failure and may progress to respiratory arrest and cardiac arrest.
Okay, any questions about the video?
Not at this point.
Okay, I like it that it actually, they actually had real sounds, right?
Yeah.
Because, those of you that didn't practice in a pediatric setting, it's, it's hit and miss, to actually hear these, sounds. So that's a good way to close the gap. Not the same as in real life, but at least some familiarity.
Yeah, it was a good video.
Yeah, great. Okay, so circulatory assessment. So as we've mentioned before, that cardiac output in pediatrics is a heart rate multiplied by a stroke volume because they're unable to increase their stroke volume. So the only way how they can increase their cardiac output is by increasing the heart rate. So therefore, heart rate should be a significant clinical marker when monitoring cardiac output in pediatric patient. So bradycardia in adult is often due to cardiac pathology, and bradycardia in peds is most likely related to hypoxia. So other uniqueness of pediatric cardiovascular function is that infants and kids have less oxygen reserves than adults, and anything that increases oxygen consumption or reduces oxygen delivery can cause decompensation. So how do we assess entire circulatory assessment in a pediatric patient? What constitutes that assessment? So we are doing heart rate, blood pressure, central and peripheral pulses. So where would be a central pulse in the pediatric population? Any idea? Where would be assessed for a central pulse? For a central pulse, we would assess, sorry?
Is that where you do brachial or do you go straight to carotid?
So under 1 year of age, the recommendation is to do a brachial. And over 1 year of age, carotid for a central pulse, and the femoral pulse, you can do it at any age. It is still considered a central pulse. Yeah, you won't find the femoral pulse assessment in the literature very much. However, in clinical settings, we still assess a femoral pulse. So you also want to assess the skin color, temperature, is it cold, is it warm to touch, moisture, and capillary refill. Acceptable capillary refill is under 2 seconds. A little bit about color. We've already talked about different colors that are abnormal. So what is the significant red flags of altered cardiovascular function in a pediatric patient? So tachycardia, abnormal color, prolonged capillary refill, greater than 2 seconds, altered level of consciousness, whether it's, lethargic or decreased response or extremely irritable. Also decreased urinary output, which sometimes it's not always, easy to measure when the patient just presents to emergency department. When you do have a patient on the floor for an extended period of time, you can calculate it and figure it out, but it's something that we rely on parents heavily in order to elicit this history of how frequently the child voids. And the late signs is decreased response to pain, flaccid tone, hypotension, and bradycardia. So disability assessment, what's under
Tanya.
this? Yeah,
Sorry, quick question.
yeah.
Are there any barriers to cap refill? Are there any times where cap refill might not be appropriate, or that there's a barrier to assessing or using it as a marker?
Not really. It's just sometimes in certain situations, cap refill could be deceptional. And again, like everything else, it has to be put in a context of other clinical conditions. For example, when patient is in vasodilated septic shock, or in other words, when we call the patient is in a warm shock, instead of vasoconstriction, you'll have a vasodilation. And actually, your capillary refill will be excellent. It will be very brisk, right? So, however, you have to assess it in light of other conditions, right? So how, what is, how does the patient, is the skin warm to touch? So usually when they're vasodilated, also you'll have bounding pulses as well, right? So you have to assess other signs and symptoms. Yeah. Okay. Most of the pediatric patients, when they're in septic shock, they will have a vasoconstriction, so they will feel cool to touch, and they'll have delayed capillary refill. In some situations, they'll be in warm shock, and there will be vasodilation, and as a result, their capillary refill will be very brisk.
Okay, thank you.
So don't let this to deceive you. Yeah. So disability assessment. So under disability assessment, we're basically assessing neurological status. Don't forget to check the glucose as well. So what's neurological sort of key differences in pediatric patients? So infants function largely at the subcortical level. They have a thin skull sutures not fused until 16 to 18 months of age, and therefore gradual rise in intracranial pressure can produce increased head circumference. Shear hemorrhages and diffuse brain injury are more common. However, kids have greater capacity to recover from head trauma, and spinal cord injury is less common in a pediatric patient compared to adults. So how do we assess neurologically the child? It is actually not that much different than adult. We do utilize AFPU scale, awake, verbal, response to verbal command, response to pain, or unresponsive. And we have it built in our neurological assessment in the power chart. Also very important to know, what is the child's baseline, right? So if this is the child that is developmentally delayed, we need to know what is the baseline. We utilize Glasgow Coma scale, and also don't forget to assess the dextrose, especially in the younger kids, because hypoglycemia can manifest in younger infants, or infants that have some metabolic and endocrine condition can manifest as an altered sort of level of consciousness. Any questions so far? All good.
I do
Glasgow.
have a question, sorry.
Yes, please.
Shear hemorrhage. What's shear hemorrhage?
So shear hemorrhage is basically intracranial hemorrhages.
Oh, okay.
Yeah. So this is a Glasgow Coma Scale. So as you notice, we have a modified Glasgow Coma Scale. We have it built in it's a validated modified pediatric Glasgow Coma Scale that we assess as indicated. So in other words, not every pediatric patient requires Glasgow Coma Scale assessment as indicated. Why it is modified? It is modified for infants because they're nonverbal. But in terms of a significance of a Glasgow Coma Scale, it is pretty much the same as adults. For example, the maximum scores that they can get on the Glasgow Coma Scale is 15. So whenever the score is between 13 to 15, it indicates mild brain injury. Whenever the score between 9 to 12, it indicates moderate brain injury. And the severe brain injury is a score from 3 to 8. 8 is already considered a critical score with 90% of patients in a coma at this level. And coma is defined as not opening eyes, not obeying commands, and not uttering understandable words. So what are the interventions when we have a child with altered level of consciousness? Again, going back to basic maintaining ABC, right? And some of them may not be able to maintain the airway. So thinking about intubation proactively, supplementary oxygen, establishing vascular access, and thinking about potential causes of their altered level of consciousness. So if it is a hypoglycemia, if we suspect hypoglycemia, we should be measuring point of care dextrose and treating with usually pediatric population, we treat it with 10 or 25% dextrose solution and checking in about 5 minutes, making sure that it goes up. If it's a hyponatremia, so treating hyponatremia. If there are seizures, then treating seizures. If we suspect an increased intracranial pressure, then making sure that we take some measures to increase intracranial pressure, such as elevating the head of the bed 30 degrees, hyperventilating, and also administering 3% hypertonic saline or mannitol. That will be a physician's decision. Also thinking about the infection and treating infection empirically with a broad spectrum antibiotics. And also don't forget about potential toxins, contacting poison control center and figure it out which toxidromes could be involved in a decreased level of consciousness. And the last element of our primary assessment is E, which stands for expose and environmental control assessment. So undress the child, examine entire body, examine underlying injury, additional signs of illness. Are there any rashes, bruising, petechiae? Don't forget, after exposing, maintaining normal body temperature, especially during the winter times in infants, providing blankets, overhead warmer, warm IV fluids, and if they're conversely, if they're febrile, providing measures to cool them down, such as removing excess clothing, and medications. All right, so I think we finished our primary assessment. Any questions so far?
Not at this point.
Okay, so what I did, I put a couple of several slides on the most common pediatric conditions that will just, I'm sure for most of you, it will be just a good review. So pediatric asthma. Pediatric asthma is the most common chronic illness in the childhood. It is a reversible airway obstruction caused by airway inflammation and bronchial hyperreactivity and obstruction of airway by thick mucus. So what happens in the pediatric asthma? Expiratory airflow limitations leading to air trapping. So there are multiple triggers. There could be viral, exercise, allergies, environmental, such as tobacco, dust, usually manifested by shortness of breath, cough, wheeze, chest tightness. History could be prior flare-ups, PICU admission, intubation, frequent ED visits, also social issues. Is there any follow-ups that the family has been doing? Any compliance with medication, any education on medication, any ability to pay for medications? And also how far is the distance to emergency room?
Sorry, can I add one thing to that?
Absolutely, you're the expert. Yeah.
For triggers, I just want to remind everyone that stress is a less thought of and less commonly known trigger, but it is a real valid trigger, in particular as girls enter their teenage years.
Oh, wow. Wow. Interested. Thank you very much for that. Definitely add to this presentation. So clinical presentation may have coarse expiratory wheeze or decreased air entry, increased work of breathing, indrawing, tracheal tugging, nasal flaring. They could be irritable, tired, or simply just happy wheezers. So in terms of the asthma management, bronchodilators such as Ventolin is a first line of therapy. Also anti-inflammatory medications such as Pediatric, dexamethasone, Atrovent is other medications that we administer to patients in asthma. And as many of you know, that there is a significant body of evidence that suggests that properly used MDI as effective as NEBs, and in some cases could be even more effective in treating acute asthma symptoms. So not sure if you're aware, but we actually have medical directives and order set in emergency department that have been implemented a few years ago, and then we continuously sort of refine and modify. So what we have in emergency department, we have built PREM scoring in triage that allows nurses, based on their PREM scoring, to implement medical directives. So for example, if the child has a PREM score between 1 and 3, then nurses in triage can administer Ventolin with a spacer 8 puffs right there. And they have a disposable air spacer in triage. So if PREM between 4 and 7, then they're giving 8 puffs, Q15, times 3, and also they're adding dexamethasone. And then whenever the PREM score between 8 to 12, that patient will be actually transferred to recess. But to start, they can give 8 puffs, Q15 times 3, and then add Atrovent as well. So that is for medical directives. Then we have an order set that physician can also order the medication for patient that is in asthma in the department. So you see on the medication, from the medication list, in terms of steroids, could be dexamethasone, prednisolone, and hydrocortisone, as well as magnesium sulfate. So very, very important on this chart to send patient home with an asthma plan, because we know there is a huge evidence that the reason of readmission is not having an asthma plan. So we also implemented on this chart, whenever patient is discharged from emergency department, they're given an specific asthma plan that is being filled out by physicians that clearly delineates, how many puffs and what to do based on their asthma symptoms exacerbation. So let's talk about status asthmaticus. Status asthmaticus is exacerbation of asthma symptoms that are unresponsive to conventional therapy. So it is characterized by a high work of breathing. Hypoxia is common, can lead to metabolic acidosis, can lead to hypercarbia and respiratory acidosis. It is life-threatening medical emergency. Management involves Ventolin, Atrovent, added to continuous naps, usually, over an hour. Quite often we experience, once the patient maximize all of their naps, those continuous naps are no longer doing much. So patient, hits a state when there is other therapies have to be implemented. And one of the therapies that we are implementing is magnesium sulfate infusion. So magnesium sulfate infusion, it is a small muscle relaxant. And usually we infuse it over an hour, but it can be infused over 20 minutes. And effect should be evident right away. And if there is an effect, it can last for up to 3 hours, and patient can reverse back, or it, sometimes there is no effect, or sometimes there is a last longing effect. If there is no improvement after magnesium sulfate infusion, usually pediatrician will call a critical, and this patient will be transferred to a higher level of care, usually to a pediatric ICU. The team will come and get the patient, and in some severe cases, they will start a Ventolin infusion IV. As a community hospital, we are not allowed to start Ventolin infusion IV. So as perhaps you also know, in asthmatic patients, we are trying our best to avoid the intubation. And intubation should be the last resort, since it increases the hyperresponsiveness of the airway, increase of their barotrauma, and therefore there is a significant increase of circulatory arrest in these patients. And again, in status asthmaticus, really have to be astute of potentially silent chest when there is absolutely no air exchange. Any experiences with the status asthmaticus? Comments?
Not lately.
Yeah,
Not
yeah,
really much.
yeah. Hopefully not too much this season. Yeah.
Yeah.
Okay. Croup. So croup is a clinical syndrome of stridor and hoarseness resulting from laryngeal inflammation and edema causing upper airway narrowing. So in other words, croup is infant child laryngitis. And again, going back to, structural difference of a pediatric airways that explains why adults are not affected by laryngitis and pediatric population very much affected. So clinically, it is usually viral in origin. Important differential diagnoses include epiglottitis, foreign body aspiration. In terms of the presentation, it happens normally in kids between 6 months and 5 years of age, with a peak around 2 years of age. And, history is really not very specific. Couple of days history of runny nose, mild fever, malaise, anorexia for a couple of days. What's very distinct in the croup patients that there is a barky cough and hoarseness. They sound like a seal. Restlessness. They may demonstrate inspiratory stridor and signs of increased respiratory effort. Direct exam of oropharynx should be only performed by an MD that is skilled in airway management. I guess because of the airway hyperreactivity, there is a high degree of airway closure. So if we really, really worry about, a severe croup, we usually will call anesthesia to have on that standby. It's that balance that you really don't want to intubate them electively, but if they need to be intubated, it has to be an airway expert to intubate them. And very, very small percentage of a croup patients that really requires those extreme measures. Most of the croup patients do improve. So because it is viral, so treatment is largely supportive, including humidified oxygen, even though there is really not a very strong evidence for humidified oxygen. In the past, we used to put these kids in croup pads, but we are no longer doing that. Again, a clinical key is to keep this child as quiet as comfortable. Separation anxiety is huge at this age. Keeps them as close as possible to the caregiver. In terms of the IV access, it's that balance. Unless we think that the child will need to be intubated, we try not to poke them, because really, if they will start crying, they can really, really close up their airway. So this is the population that you want to stimulate them as less as possible. So anti-inflammatory medication, dexamethasone, PO is very helpful. Again, in extreme situation, when they do have IV access, we'll give it by IV. And antibiotics are not effective because it's viral. And also epinephrine inhalations for severe croup tend to be effective. And if they need them, we can repeat them twice. And then patient has to be observed in emergency department at least for 4 hours because of increased heart rate, and to make sure that they do respond to the medication.
Tanya, the
Yes.
epi is also available MDI now.
Yes,
Sorry,
epi. Yeah, thank you, Mika, for bringing it up.
Problem.
Yeah, so epi, yes, available via MDI in emerge and inpatient pediatric. Unfortunately, last year we did not see any croup, so we really did not have a chance to test the efficacy of epi MDI, but we do have it available. Yeah, thank you. Bronchiolitis. So bronchiolitis is a lower respiratory tract viral illness. It is predominantly caused by RSV, respiratory syncytial virus, but it can be also caused by adenovirus, influenza, and parainfluenza. Peak incidences are midwinter to early spring, typically affects infants that are less than 24 months of age. So what happens is there is an inflammation of the bronchioles, increased mucus production, airway edema, small airway obstruction, and trapping. And RSV tend to be more of a severe form of bronchiolitis, as I'm sure some of you already know. So in terms of the clinical presentation, it includes a couple of days history of upper respiratory tract infection and fever, tachypnea, wheezing. Also, there could be inspiratory and expiratory wheezing, crackles, retractions, sometimes apnea and cyanosis. Basically, there is no one definitive diagnosis. So it is diagnosed based on a patient's history and physical exam. Routine lab tests and chest x-ray are not very helpful, but sometimes it is done, chest x-ray, just to rule out the other respiratory illnesses such as pneumonia. And the COVID-19 viral testing will be actually starting in a couple of weeks, incorporated in our viral testing as well. Management. So bronchiolitis management. So supportive care is a cornerstone of treatment of bronchiolitis. Main management goals are to ensure that adequate oxygenation and hydration. In terms of the oxygenation, supplemental oxygen is only necessary if oxygen saturations are persistently less than 90%. And as you notice, a lot of physicians will order oxygen saturations to be checked intermittently, not continuously. Suctioning is very important, especially in young infants, because they're primarily nose breathers. So kids with bronchiolitis tend to have a lot of nasal secretions. And as you've noticed, once you clear those airways, their work of breathing will improve. High flow nasal cannula, as you know, have been revolutionary in managing bronchiolitis. In the past, there's been a significant volume of moderate bronchiolitises that we did have to intubate and send to a higher level of care. So there is still a very small percentage of a severe bronchiolitis that we still may have to intubate, but a lot of our moderate bronchiolitis we're able to manage on high flow. Again, don't forget about hydration, because these kids are, in respiratory distress. They're not, their PO intake is affected. So we need to ensure that they're optimally hydrated through NG feeds, many times through IV hydration. And in terms of the medications, unfortunately, there is not much that we can offer. So there is no evidence to support any of the following treatments for bronchiolitis. So Ventolin, we can try, but if it does not work, do not continue. Atrovent is not recommended. Steroids are not recommended. Antibiotics are not recommended. So treatment is primarily supportive. And hopefully in a few days, they will write it out. Any questions about bronchiolitis? Any comments?
The nasal suctioning, I mean, that's not something I'm very fond of. And I think sometimes you end up causing trauma, swelling. I know and you're saying for 4 months of age and younger, I know I've been called to suction infants and nasally. The nurse can't do it, but at any rate, I still don't like doing it. Yeah. I think, how long we've been on the planet and there's no nasal suctioning. Did anybody ever die? You know what I mean? Like I don't believe in inflicting trauma.
It is, you're right, it is that balance, right? But, if they can't breathe through their nose, it's becoming really, really, challenging. Yeah. It's a balancing, keeping the airway clear and, inflicting trauma. I agree with you.
Yeah, I think it's one of those on the moment decisions where
Mm-hmm.
we have to
Mm-hmm.
clinically assess, is the
Mm-hmm.
section going to be of benefit, or is it
Exactly.
is
Can,
it just
yeah.
their little nasal passages are so swollen just from inflammation and therefore it
Ex
won't be effective?
yeah, and therefore it in itself causes obstruction. Yeah.
Is it
Yeah.
fevers that
I
are
think,
blocking it, or
yeah,
is it
yeah,
inflammation?
yeah. I think, yeah, it is, a
They get
clinical.
suffocated? No, they opened their mouth.
Yeah.
Like, I just,
Yeah.
I find it very, I don't know,
Yeah.
not fond of it. Been
Yeah.
doing this 30 years and
Yeah.
geez, now all of a sudden
Yeah.
it's become the regular,
Yeah,
call
yeah.
the RT for
Yeah.
nasal suctioning.
It's
like,
different if it's like a meconium post-delivery
Well,
versus
Yeah. Yeah.
something worse.
Yeah.
Yeah.
I think it's case
Overrated.
by case, and it's sort of, like this balance, clinical judgment, right? What's going to help and what's going to cause more harm.
Yeah.
Yeah. Okay, a few more slides, and we will be done soon on pediatric shock. So shock is it happens when cardiac output is inadequate to meet metabolic demands. So there are different types of shocks: hypovolemic shock, cardiogenic shock, septic shock, neurogenic shock. Out of all of those shocks, hypovolemic and septic shock is the most common. And signs and symptoms could be subtle and non-specific in children. And we actually recently implemented a sepsis triggered tool in the emergency department. It is an evidence-based sepsis trigger that basically allows a prompt physician assessment and treatment of patients that could be potentially in a septic shock. And it's based on vital signs and perfusion. So what is the signs of poor perfusion, or in other words, that patient could be potentially in a septic shock? Tachycardia, mottled color. And actually this picture is a demonstration of how, mottled color can look like. So this is quite a profoundly mottled infant. Mottled color, paler, cool skin, prolonged capillary refill, longer than 2 seconds, decreased urinary output, diminished intensity of peripheral pulses, metabolic acidosis, and morpholate signs are changing responsiveness, hypotension that imminently leads to bradycardia and cardiac arrest. So shock management is early recognition. Signs and symptoms could be quite subtle. You could have 2 abnormal vital signs. For example, the patient could have tachycardia and fever and could be in septic shock. How many pediatric patients that are walking into emergency department have tachycardia and fever? Very many patients, right? But at least when you do have this trigger, you scoop these patients up and you actually prompt more detailed assessment by physician that decides, is this patient in an early stage of shock? And every patient we want to catch in an early or compensated state of shock, because once they hit decompensated or a hypotensive state of shock, which a hallmark of a hypotensive state of shock is a hypotension. No matter how aggressively we will be resuscitating this patient, we may not be able to save this patient because there is a significant organ and tissue damage that has occurred. So therefore, early recognition is the key. Again, management of ABC, putting oxygen on and establishing rapid IV access. 2 large bore IVs and depending on how severe the stage of shock, sometimes physician will order, if IV cannot be readily obtained in 5 minutes, go straight for IO, even if the patient is conscious. Rapid fluid boluses administration. If it is a septic shock, it's really important to get stat antibiotics within a first hour. And if patient after rapid fluid boluses still fluid refractory, so in other words, if the blood pressure is still not up, then starting pressors such as epinephrine and norepinephrine. Okay, so
Sorry, quick
yes,
question. The fluid
yes,
bolus, the
yeah.
10 to 20 mils per kilo times 3, is that
Mhm.
across the span of ages for pediatrics?
Yes, it is across a span of
Okay.
ages, but not every patient will require 3 fluid boluses. So some patients can improve after 1 bolus. Some patients will require after 2 fluid boluses. Some patients will need 3 fluid boluses and still will not respond. So
Yeah.
the key is to reassess after each fluid boluses. So reassess the signs of perfusion, so whether the patient has responded, and also to reassess whether the patient has tolerated the fluid bolus. So many patients may not tolerate a fluid bolus and experience a fluid overload. And as a result, we would rather move to pressors sooner because we don't want, to experience another complication such as pulmonary edema and think about ventilation of this patient.
And
Yeah.
is it normal saline or Ringer's lactate? That's the
Normal
fluid?
saline.
Okay.
Normal saline. Again, if it's a shock that is related to a blood loss, in some situations we will be giving also O negative blood. The only exception I would say for cardiogenic shock, we have to be more careful with fluid boluses. Instead of using 20 mils, use 10 mils and give it more slowly, versus in a hypovolemic and septic shock, you really want to give rapid boluses in about 5 to 10 minutes. In cardiogenic shock, you want to give fluid boluses slowly over 20 minutes and 10 mils per kilo. Yeah, and go to pressors sooner.
Yeah.
And obviously consult with a cardiac tertiary care center for pressors, because the choice of pressors could be not always epinephrine. It could be milrinone. Any other questions about shock or anything else?
Not yet.
Okay, great. So we're actually our last slide. So just to summarize the tips for pediatric assessment, communications can be quite challenging. Deterioration can occur quickly and rapidly with no advanced signs. Don't forget about the separation anxiety. Keep the child as close as possible to a caregiver, especially young kids. Expose the whole body, one area at a time. Move from least to most invasive. Assess repeatedly and frequently, and beware of a silent or extremely irritable child. Okay, I hope you had fun, and I hope it was useful. Any other questions?
Yeah, thank you, Tanya. That was so useful.
Yeah.
I had fun. Any
Okay.
questions from our virtual group? I'll just list up the names. Dimitri, Charlie, Larry, Jill, Annam, and Martha.